We have tried throughout the life of this board to work very informally across strategic development, so that before each of our formal meetings there's normally what we call a development session, and yesterday we spent some time thinking through the board planning process for next year, some time also thinking about the new models of care under the 5-year forward view, because I'm very keen that before business comes formally to the board, every member of the board, executive and non-executive, has been involved in the early stage thinking. It has to be that way if we're to have a sophisticated approach to board leadership and governance. We meet this morning in public, but we will follow that with a meeting in private session. I'm insistent that that which comes to private session should be that which, by virtue of its confidentiality, whether it's related to contractual matters or some other area where it would be improper to have public disclosure, must be brought to the private meeting, but with a justification for it coming to the public meeting. The presumption always is that business comes here and isn't taken by us privately. So that's by way of introduction to the agenda this morning. Let me now formally declare the meeting open, and to give the normal assurance that there is no fire alarm scheduled for this morning. Should the alarm go off, our staff will escort everybody to a place of safety. Secondly, to invite declarations of interest in matters on the agenda. I shall kick off because the agenda and also the forward business of the board, particularly around cancer, involves a close working relationship with Cancer Research UK, and I have a family member who is an employee of Cancer Research UK. May I invite other declarations? Moira Gibb.
Malcolm, just for the record, I'm chair of Skills for Care, which is mentioned in the report later.
Thank you. We'll record that. Other expressions?
I should just say that NHS is a provider of learning disability services. No, that's
I'm not sure whether that was heard, but
NHS, Turning Point.
Turning
England.
Point.
Sorry, I must say Turning Point
That's
is a
right.
provider of learning disability services.
The medical device company in my spare time.
Okay, well, we'll try and ensure there's as little of that as possible. So, I think, does that cover declarations? Right. I then would like formally to record apologies for absence this morning from Kieran Devane, who, in his new role as Director General of the British Council, is currently in Pakistan, but he has sent me his detailed comments on the papers, which I've recorded with the team, and where appropriate I'll draw attention to this morning. Next issue is the agenda. There are items of reports under item 11 from board committees. I've been assured by those from Finance and Investment and from Audit and Risk that we won't have an oral report and we'll leave them as starred items. However, with the permission of the board, I would like to add an oral report from the new Strategic Commissioning and Assurance Committee, which met for the first time yesterday, and when we reach that point in the agenda I'll invite its chairman, David Roberts, to give us that report. May we then turn to the minutes of the last meeting. May I take them as an accurate record and sign them on your behalf? Thank you. I've had no comments on matters arising from them that are not otherwise on the agenda this morning. I've gone through them and I have assured myself that those items which involve further action are in hand and being taken forward. Are there any matters arising from the minutes otherwise? No. Okay, thank you very much. I turn now to the Chief Executive's report. Simon.
Thanks, Malcolm. It goes without saying that the winter period has been tremendously busy for frontline staff right across the National Health Service, and that, I think, it means that it's an appropriate moment to record our collective thanks for the enormous effort that people have made to ensure that patients have continued to receive high quality, safe and responsive services over this period. We will be discussing a bit later the performance, not only on the urgent and emergency care services, but also more broadly across the National Health Service. Suffice it to say that I take the view that what we have seen over the winter period only serves to underline the importance of the broader agenda that has been set in the 5-year forward view, and in particular the need for the changes that Bruce's urgent and emergency care review hold in prospect, and that we can see that there are 4 concrete things that the health service needs to continue to do in order to ensure that we have resilient urgent services going into next winter. The first is that we need to continue to ensure we have the right capacity, not just in A&E departments and hospitals, but also in community services, GP services and social care. Secondly, all parts of the system need to continue to work together effectively with better care coordination between individual services. Thirdly, we know that we have an opportunity still to improve clinical processes inside individual hospitals. And fourthly, we know that we need to redesign the urgent care front door of the National Health Service, particularly the A&E 111 out of hours GP 999 system, so that that is easier for patients to navigate and people get the right care at the right time. So that 4-part agenda is front and centre in terms of what the health service is going to have to be working on over the course of the next year. None of that undermines the fact that our staff, nurses, doctors, paramedics, many others, have been working flat out over this period, and we owe them a debt of thanks. Inevitably, we are at a period where, not just on the back of the winter pressures, but more generally, the National Health Service is under the national spotlight. I think it's therefore worth just taking a moment again to congratulate everybody working in the health service for the stunning results published today in the latest British Social Attitude Survey, which has been going 29 years now, and today we see that the National Health Service is at its second highest ever level of public satisfaction. So back in 2001, 38%, just over a third of people in this country were satisfied with the National Health Service. Now we are at 2/3. So that's been a huge increase, and the level of dissatisfaction with the NHS is the lowest that it has ever been recorded. And that is true not just in general practice services, which are the highest of the services that people are satisfied with, but we've seen big improvements in satisfaction with outpatient services as well. A&E services, satisfaction has risen over the course of the last year, and at a time of inevitable partisan debate, it's also worth recording that satisfaction levels with the National Health Service are comparable between supporters of all 3 main political parties. So that is, I think, a moment to just inject a note of reality into the debate about the National Health Service and to remind ourselves of its importance as a national institution capable of bringing the country together. Since we last met, there have been some specific developments that we have undertaken. We have continued with the joint effort with the Royal College of General Practitioners and the GPC to strengthen primary care, both with a 10-point plan on the 3 Rs, as Maureen Baker calls them, namely recruitment, retention and returners, and also the launch of the process by which GPs across the country can bid for a share of the £250 million of extra funding to strengthen primary care infrastructure beginning next year. On cancer services, we have launched the new National Task Force on Cancer, chaired by Harpal Kumar, which will produce a view on how to put flesh on the bones of the headline commitments we made in the forward view, both in March and in the summer, which we think will chart a good course for further improvement in cancer services in this country over the next 5 years, recognising again, and it's easy to sometimes skate over these facts, that in 1997, the 1-year survival rates for cancers in this country was 59%. By 2012, that had become 69%. So cancer survival rates are at the highest levels ever, but we know we've got more work to do, and charting that course is what the independent task force chaired by Harper will help us do. On mental health, work continues on readiness for the new access standards. We'll shortly be publishing the results of the Children and Adolescent Mental Health Service Task Force, where we know further action is also required. I'm not going to talk about the forward view or other matters since they come up on our agenda, but suffice it to say that I think there is a lot of eagerness across the sector to get going on that agenda. The session that we had with a number of providers and CCGs last Friday that a number of board members were at with Don Berwick at the King's Fund was well attended, and as I think Ian will report momentarily, there is a high degree of interest in working with us and our national partners on the new care models beginning from April. Why don't I leave it there, Malcolm, see if there are questions.
No, thank you very much, Simon. Can I invite any questions from members of the board? No, well, thank you very much for the report, and as you say, some of the items will come back in the course of the agenda, but I would like, please, the board to agree that we formally record our appreciation to NHS staff who ensured, working under the most difficult circumstances over Christmas and the New Year with that peak of demand, for their extraordinary contribution to the health and welfare of our patients. Yeah. Thank you. May we move then to a 5-year forward view, item 4 on the agenda. I'm going to invite Ian Dodge to introduce the paper. Ian.
I invite the board to note the strong progress made in the approach to implementing the forward view on 3 areas. First, in building strong partnerships, NHS England with our 5 other co-authors of the forward view, and with our national voluntary sector partners and myriad others. Secondly, in creating capabilities that mean that we will be able to be confident of taking forward the many initiatives in the forward view, including supporting vanguard sites who will be selected for the work on new care models. I'm delighted to have recruited Samantha Jones as the director of that programme and enlisted the support of Sir Sam Everington, the chair of Tower Hamlets CCG, and Simon referred to the support that Don Berwick will be providing as our international advisor. And third and finally, I wanted to refer to the high level of energy that we've been generating in the NHS, not just in relation to the new care models, but many of the other initiatives, including, for example, the National Diabetes Prevention Programme that we will be launching. We published earlier this week a brief supplementary note on new care models. The deadline for registrations of interest is the 9th of February, and already we are seeing very many applications. And I believe that this bodes well for the success of the programme, Chair.
Ian, thank you very much. I mean, the NHS has got a brilliant history of strategic planning, and implementation has never lived quite up to the promise. I think what the board is really interested on this occasion is to try to ensure that this is not a repeat of history, and to try to ensure that we're going to be able to capture the energy to which you've referred. What do you think will be the key means through which we're going to be able to do this over the coming months?
Through, I think, building the alignment of national partners is critical. So the strength of the coalition between ourselves and Monitor and the TDA in particular will be vitally important, so that the experience of local commissioners and providers wishing to innovate is of support and understanding. So I think that's the first precondition, and I'm very confident that we will be able to achieve that. I think, secondly, we need to build a set of capabilities and capacity to support the places that will be showing the way in developing these new care models. And collectively, the Board of NHS England is putting its weight behind that process, as indeed our partners are. And then thirdly, I think we need to, as we were discussing yesterday in the board development session that you alluded to, Chair, we need to frame our approach very carefully. We need to think about how we can learn from some of the previous initiatives around creating pilots in order that we can generate replicable models. So the places that we want to work with in 1516, we have two goals for those places, one of which is that they will be solving problems and creating solutions for their own local communities. But secondly, that they will be part of a cohort of sites and areas that are trying to do similar things, so that we can generate solutions in common, whether this is around the creation of new workforce roles, thinking about infrastructure, the use of digital technology, procurement, contracting, payment mechanisms. That means that we're not just generating unique solutions for each community, but approaches that can then easily be adopted by the subsequent waves.
Good. Thank you for that. Let me invite further questions. Moira.
A couple of specific questions, Malcolm, to Ian, really. Whether the workforce board, because I think it's a very good comprehensive progress, really, in a short space of time to get all of this corral. But the workforce board will look at the workforce in social care as well as in healthcare, and I've declared my interest on skills for care earlier. And secondly, whether around the 9 geographies to lead the development of integrated personalised commissioning, was that the choice of those also linked to replicability or other criteria, I suppose?
So if we are going to redesign care around the needs of individuals, then that must mean that we look at their care needs holistically, including social care. So the development of new approaches both to integrated commissioning and then the generation of new models of supply absolutely has to be a joint endeavour with our local authority partners and commissioners and providers of social care services. And so the work of the Workforce Board has to address those sets of issues. On integrated personalised commissioning, for exactly the same reason, because this programme is about the joining together of the NHS pound and the local authority pound. So it is a joint endeavour between NHS England with our CCG partners and critically local government colleagues. And in selecting these sites, we are looking to try and develop new models and approaches that can be easily then adopted by others. We had strong interest in the programme, and we are confident that the places that we have selected will be able to work together, as I was alluding to earlier, not just in solving their own communities' problems, but in developing new models that will have a wider resonance for the NHS and social care more widely.
Right, Ian, I think I make no apology for the fact that the board's going to be totally obsessed by the 5-year forward view and the new models of care, and I will come back to this at every one of our meetings, but also working solidly as a team behind the strategy and hoping to build on everything that's been achieved to date. As you say, the engagement of local government, I think, is absolutely critical to this in models which bring in social care alongside healthcare. So I think we have an opportunity to devise wholly new ways of providing care that are suited to local communities in different geographies. But we will look forward to further reports at each meeting of the board, and we'll, I think, hold you strongly to account on driving through the progress. Thank you. Right.
Shall I just give a quick perspective on the connection of this to the Leadership Academy and IQ?
Yes, I'd be grateful, please.
I mean, we are in the middle and coming to a set of conclusions on the review of the NHS IQ and Leadership Academy, and it's been a highly collaborative effort with all of the major people around the table. We've been surveying people's perspectives on these and gathering hard evidence, and our starting point was actually the 5-year forward view and what is the leadership capability, capacity improvement agenda that needs to be established with that 5-year forward view in mind. And I think our conclusions are going to be quite radical about the need to connect some of the IQ work closer to the to the coalface, if you like, to the operations. And I think on the Leadership Academy, you know, we can't expect the Leadership Academy to fulfil all of the capacity and capability building that's required in the NHS. You know, this is a job of leaders, developing leaders in workplace. It's a matter for talent management in workplace. It's a matter for then looking at talent management across the systems. And the Leadership Academy does good work, but it's a piece of the whole leadership capability, which I think is not connected enough. And I think some of our conclusions will be about a more systems-based view of leadership, and Victor and I are working quite hard with that sort of systems-based perspective in mind. We aim to bring something to the board at the end of March, and as we sort of emerge with our conclusions, Malcolm, and I'm sensitive to making sure that we do that with our colleagues rather than just as NHS England. I don't know, Victor, if you want to add anything to that.
No, not really. No, I think you've summarised the position quite well.
Thank you, Ed. Thank you, Victor.